Hi, everybody. It's Professor Miller. This lecture is going to cover a pain assessment for Chapter 10. The reason I wanted to go into this first is because it does affect other systems, and I feel like it's something that we need to talk about before we even go into like different systems like cardiac, GI, etc. Because pain affects everything essentially, and when you're obtaining a health history and all that, it definitely can change your approach and looking at other factors as well. So I wanted to cover this before we move into other systems essentially. Pain, you'll hear this used a lot. Pain has been noted as like the fifth vital sign. About probably 15, 20 years ago, they included it and making sure that patients are always being treated appropriately for pain. And essentially recognizing that it's a complex and very subjective experience for the patient. So making sure that we're always treating pain appropriately for each patient. More recently, and I'm sure you probably have all heard of it, is the issue with the opioid epidemic. So nowadays, unfortunately, it's become a area where you have to weigh the benefits and really look at your patient closely, because you have to treat patients. You can't just assume that everybody is using opioids because they're using it for, substance abuse. You have to treat people appropriately and, not have that bias there. So it's actually become problematic recently. That's my opinion on it, but I feel like patients are actually being undertreated now because of it. So we have to find a healthy balance between treating pain and also, doing it responsibly. When we talk about pain, it's very, very subjective. So pain is always subjective. It's the patient's feelings, it's how they, perceive it. It's very complex because it does originate within the brain, your central nervous system, your peripheral nervous system, and we'll talk about a few different types of pain too, so it kind of clarifies this a little bit more. So we have nociceptors, and these are like the nerve endings that detect sensations, essentially, and that's where the pain is originated, peripherally. And this is what carries it to your central nervous system or up to your brain. These are all over, so they're located within your skin, connective tissue, muscle, your abdomen, your pelvic viscera, so your internal organs as well. So that's why people will have pain when, like you have appendicitis or something like that. So this is what transmits this painful sensation to your central nervous system to perceive it. They're stimulated either by trauma or injury or chemical mediators. Chemical mediators is essentially like those inflammatory mediators like prostaglandins and stuff like that. So when you have inflammation, like if a patient had cellulitis or something like that, they're going to have pain there because of that inflammatory response or chemical response there. And it does trigger this, response back up to the central nervous system. So a few different types of pain, and I wanted to cover this because it helps you understand that neuropathic pain, like that peripheral neuropathy or different areas, or post-herpetic neuralgia, which is from like shingles. Nociceptive pain is the one that I'm talking about when you have tissue damage or you have an incision or you have trauma to an area or postoperative pain. This is like that typical general pain that you would think about essentially. Now in the middle we do have mixed, so that it'd be a combination of like typical pain and neuropathic pain. Neuropathic pain is very complex, and I'll give you some examples here. But trigeminal neuralgia is actually your trigeminal nerve is in your up in your face, and these are really complex because you can't see it essentially. So same thing with like diabetic neuropathy. You can't see any abnormal, skin tissue there, but it's all at that micro level of the nerves essentially. So like trigeminal neuralgia, a lot of these too are very, very painful. Like trigeminal neuralgia, I mean, patients will have, neurosurgery for this. I mean, it's that bad. I mean, so neuropathic pain can be very excruciating for a patient. And a lot of times, because we can't see it, we kind of disregard it. And it's unfortunate. We cannot do that, obviously. So you really have to look at the context of the patient and look at, their history, what's going on with them, and, where it could possibly be stemming from. Neuropathic, like low back pain, that's the other thing. Like a lot of patients that have, like a herniated disc, it pushes on that nerve and they have that nerve pain. And they could have nerve pain like down the leg, they could have it in the foot, their knee. So it's not even just at that back site, like by your back. It would be in the, like running along those dermatomes. Post-herpetic neuralgia, like I said, that's with herpes zoster. This is hugely problematic. A lot of older adults that have herpes zoster or shingles, it's unfortunately they end up with post-herpetic neuralgia. It doesn't, sometimes it goes away within 6 to 8 months or a year, or sometimes it lasts a long time. But it's highly linked with like depression and all that. And a lot of these neuropathic disease processes are linked with depression. Um, Complex regional pain syndrome, you probably have never heard of it, honestly. Like I didn't really know much about it until probably about, 6, 7 years ago when I worked in orthopedics. A lot of times too, it's related to, not always, but it can be related to a trauma. They'll endure some kind of trauma, whether it's a fall or a fracture. And it's really odd. If you ever look it up, I'm not going to test you on this. It's just as FYI information. But let's say I had a patient actually that had I think it was a knee injury. But afterwards, she started developing all these, very odd symptoms in her leg, like very like a neuropathy type pain, and they actually get these sympathetic responses, and they actually will have like their leg will look like cool or not look feel cool or look pale, like so they start to get those vascular changes with it too. It's kind of an odd diagnosis, but unfortunately we see it fairly frequently. So it's important to understand that neuropathic pain is there. It's a lot of times very, very problematic for the patient. So we have to make sure that we are addressing that essentially. This is just kind of stuff that I already went through. You can't see it. So a lot of times, even when we do like a CT scan or an MRI, you can't see it. You cannot see, nerves that are running down the leg, essentially. I mean, unless you're doing, I don't know. I mean, you can to some extent, but a lot of times we'll do like an EMG, and EMG looks at that nerve conduction, going down. Like for instance, if someone had a neck injury and they have arm pain, and we can't tell sometimes whether the nerve pain is coming from the arm, like do they have an arm injury or is it coming from the neck? So we'll do an EMG, and the EMG will look at, where it's originating from. Is it originating up from the spine, or is it originating within the arm? So that's just FYI information. But we have to recognize that this is pain for the patient. Visceral pain, it's exactly what you think of. It would be like your kidney, your stomach, your gallbladder. So a lot of patients have gallbladder issues. A lot of patients have pancreatitis, kidney stones. This is what we call visceral pain. A lot of times with visceral pain, not always, but with certain ones, they can have referred pain with it. And actually, I'll go through that in a few slides. But it can result from basically like inflammation or injury within that organ, or if they have a tumor there, or if they have ischemia. Ischemia is lack of blood flow. So you may see this with somebody that has like a bowel issue or like a perforation or something like that. And sometimes they'll have distension with it. It just kind of depends on what's going on with it. Like I said, some examples would be like appendicitis, ulcer pain. So if they have a gastric ulcer, cholecystitis is your gallbladder. That would be that's for basically gallstones or something like that. So this is all transmitted through your autonomic nervous system. But it's important to understand too. That's why a lot of these patients have